This podcast is powered by Feinberg Consulting and intervention, case management, coaching, and companion service. Hi, welcome to Resilient Butterfly, a podcast powered by Feinberg Consulting. I'm Pam Feinberg-Rivkin, and today I have as my guest an amazing man that I met actually just last summer, but he's done some work with us in the past. It's been really remarkable. And his name is Dr. Jason Schiffman. He's the founder and chief executive officer of Camden Center in Los Angeles and San Francisco. You haven't started another one yet, have you?
Not yet.
Okay. Dr. Schiffman is an MD, has an MA, an MBA. He's a diplomat of the National Board of Psychiatry and Neurology and is a certified addiction medicine by the American Board of Preventative Medicine. He's also the founder and medical director of the UCLA Dual Diagnosis Program and has written extensively on subjects of addiction, trauma, anxiety, and depression. Dr. Schiffman has also recently written a book, which is in the process of being published with Penguin Random House, correct?
Yes, I'm in the process of, yes. It's not completed yet, so
okay.
but I'm still,
Awesome.
we haven't hit the due date yet, so it's in the works.
That's great. I'm going to call you Jason because I've felt such a familiarity with you, and I was with you too in our conversation, and it was just really nice and refreshing to hear your perspective and philosophy on a lot of what's going on in the medical field and mental health and addiction and all of it, sometimes intertwined a lot. So thank you for being here. I'm excited to have you talk on so many topics, which I think may include, and you choose where you want to go first, your personal recovery story, why did you start Camden Center, and what does Camden Center do? Talking about the trauma, physical symptoms, and diagnoses that come after trauma, along with a mental health and addiction. And what's your book about? So where do you want to begin?
Wow. Well, those are all definitely interrelated topics. And so if we start with one, we can probably pretty seamlessly shift to another.
Okay.
Maybe what would be easiest to start with is, I can start with why what Camden Center is and why I created Camden Center. And then I think from there we can, like I said, probably seamlessly move into any of those other topics. So as you mentioned in that very nice preamble, I'm a psychiatrist and I'm also boarded in addiction medicine. I'm also in recovery from addiction myself. I've been sober just over 20 years.
Yeah, your story was remarkable when you told me that last summer. So,
well, and I guess the connection between that and what I do professionally is that, when I first got into recovery 20 years ago, the available tools for someone who was trying to recover were more limited than they are now. Mm-hmm. So that's the good news, is that I think in the last 20 years, there's been a lot of progress and a lot of there's been a lot of new modalities, I think, that can be very helpful. I think one of the things that was true then that remains true is that the mental health care and addiction treatment industry is incredibly fragmented. And I do personally believe that that is the primary reason for the less than stellar outcomes that we see in mental health and addiction recovery. I personally don't view them as sort of these incredibly treatment refractory illnesses that are treatment refractory by their nature. I see that more as a consequence of the fragmented system of care. In general, I think in the U.S. health system, probably just in the Western medical system in general, there's certain things we do very well. And sort of the distribution of labor, so to speak, among all the different specialties has resulted in incredible advancement and incredibly high quality care within all of the many different medical specialties and
Where
subspecialties.
where would you say those specialties would be? I could guess.
Well,
but-
I'm just saying in general, I'm talking about the entire medical field.
Sure.
The problem is just if somebody has a condition that requires any degree of collaboration or coordination between those specialties, that's where the current system, I think, really fails.
I could
and
agree with
so,
you more.
And so I think, and I think that is particularly true within mental health, which is really unfortunate because I would say probably more than any other system within the body, mental health conditions really require coordinated, integrated collaboration among multiple different specialists. So it is a little bit of this irony that I think the part of the field that requires it the most probably has the least amount of integration. And that was really why I started Camden. I mean, Camden basically is a medical organization that provides medical care, but integrates it with behavioral health care. So every patient at Camden Center, for example, works with an internal medicine physician, a psychiatrist, multiple psychotherapists of practicing multiple different modalities, and then what we call somatic work, and that includes nutrition, physical exercise, and then all sorts of modalities that help regulate the autonomic nervous system, like massage, acupuncture, Tai Chi, Qigong, et cetera. I think we're one of the only places that really provides integration across all of those different specialties. At Camden, we use a framework, a clinical framework that provides what I call an etiologic diagnosis, which is in addition to the DSM diagnoses. And again, DSM diagnoses are made just based on lists of symptoms. This framework that we use at Camden Center that I developed, called the Camden Diagnostic Ontology, for each patient allows us to create to add to their DSM diagnosis an understanding of the etiology, meaning the cause of that diagnosis. Because unlike a broken arm where the cause doesn't matter, the treatment doesn't depend on the cause. Two people with identical DSM diagnoses will have very different pathways to reach to the causes that underlie that diagnosis, and their treatment will depend critically upon what that individual idiosyncratic path was.
So I want to talk to you with you a little bit about the different diseases or disorders that may come into Camden Center and bring up autoimmune diseases.
Sure.
How often do you see them in chronic pain and coming from the mental health and the addiction, and all of those go like the chicken and the egg? What started it, and how do you look for the underlying cause, and where do you even begin in those situations? Because they're complex, obviously.
Yeah. So we treat quite a few patients with a broad variety of autoimmune diseases. And I would go a step further to say that, there are patients that we will treat that have what I believe is likely an inflammatory system contribution to their clinical picture, whether or not they in fact have been diagnosed with a specific autoimmune disease, right? So, there's certain autoimmune diseases that are very well characterized, like lupus, and we know in fact what the underlying mechanism is, and there's very clear sort of binary tests for that. But what is well known is that there is a interaction between the cognitive emotional system and the immune system. So, for example, people in major depressive episodes very often will have upregulated what are called inflammatory cytokines, particularly interleukin-6, other ones, and the path, it goes vice versa, right? So very often people in chronic inflammatory states, whether it's due to an autoimmune disease, whether it's due to bacterial overgrowth from the colon into the small bowel, something called SIBO, these can result in contributions towards major depressive episodes, anxiety disorders, et cetera. This again gets back to what I was saying about the problem with the fragmentation of the mental health system. Typically someone that you're going to go see an endocrinologist or perhaps a rheumatologist if you have an autoimmune disorder. and that the chances of that individual or that physician having a collaborative, ongoing relationship, communication with your psychiatrist, and then that person having a collaborative, ongoing communication with therapists that you may be seeing it just doesn't happen.
Sure.
And
I want to say that that's why I founded my company almost 30 years ago to do that, because of even then, 30 years ago, there was a fragmentation, and even more so now. There's very rare that a physician will call another physician and have that collaboration.
yeah, the system just doesn't incentivize it, I mean, and that's the unfortunate thing. And, I think a lot of times when we look at systems that aren't working well, we want to find sort of a bad person or a bad group that's exploiting others. And I don't think that there's some sort of conspiracy. I don't think it's any particular person or group's fault. I just think that the nature of, when you have a medical system that exists within a market economy, a free market economy, this is sort of one of the emergent properties that happens. And I don't think it's inevitable. And in fact, I know it's not inevitable, because that's, what we're doing at Camden is very different. But it does take a recognition of the problem in order to fix the problem. And then it also requires finding high quality, well-trained clinicians that like to work collaboratively and are able to have enough humility to understand that, they can be a contributor to an overall picture, but may not know everything, and so that I would say probably one of the greatest challenges over the past decade or so that I've been running Camden has really been finding these very, very high quality, well-trained clinicians across different modalities that have the temperament to really be able to work collaboratively.
Sure. So would you say that Camden Center was started as a result of your own story?
I would say so, to some degree. So I guess this is the pivoting over into my personal story. So I originally got sober about 3 years before I started medical school. And I didn't go to medical school until relatively late. I didn't start medical school until I was 30. Had a failed career in music. Prior to that, I went to graduate school for linguistics. I just had a lot of other interests, including drugs.
Did you grow up in Los Angeles, or where did you?
I grew up in the San Francisco Bay Area, and then I moved to Los Angeles in 1991 to go to undergrad.
Oh, well, okay.
So, but in any case, when I started medical school, I was about 3 years sober, maybe a little bit less. Which I had done exclusively through participation in 12-step groups. Actually, that's not totally true. I went to an outpatient cognitive behavioral therapy treatment for a few weeks at the very beginning. Mm-hmm. But that it was back then. It was sort of 12-step or nothing. And even if you went to go to a therapist, all the therapists that worked with addicts were people in their own recovery who, because there's nothing else that had gotten sober in 12-step. And I wouldn't have been able to get sober or stay sober had it not been for participation in 12-step. But I also had a whole host of other issues related to developmental trauma and other things for which 12-step isn't the tool that you use.
Exactly.
And so, 12-step was doing a great job at what it was intended to do, but, I had additional issues. And so I ended up trying to find help for those things, but just kind of get, in those first 3 years of recovery, and was just sort of consistently just pointed back to just going to meetings. And
was there any, even then in 1990, you say 1991, right?
It was the first sobriety date was January 13th, 2001.
Okay, 2001. Yeah. So when that occurred, was trauma recognized as a precursor to addiction?
I would say probably among some groups of clinicians, but by no means was that the predominant view. And in fact, back then, the view really was that addiction and mental health were fundamentally two separate things. Mm-hmm. To this day, they are regulated as two separate things. Sure. You can open up. In fact, one of the things that my book is about is actually the horrific adverse consequences that have come to pass as a consequence of addiction being treated as something separate from the rest of healthcare. It is carved out and freed from all of the regulatory oversight that is there that protects patients with any other health
Sure.
issue. Patients are not protected, and so anyone with no credentials can open up a treatment center. Whereas if you want to provide medical services, to provide any type of medical care for any other type of condition, you either have to be a physician or you have to be a professional medical corporation, at least in the majority of the states. Not so for addiction, and that's why we end up seeing these horrific human rights violations taking place all the time, including to this day in a overwhelming number of addiction treatment centers throughout the U.S. But getting back to the main point, though, I ended up relapsing towards the end of my first year of medical school, and then I had 4 little what are called chipping relapses in that time, just a few days apiece. The last of which was the first day of my second year of med school, and I had a very, very bad overdose on heroin. And I had multi-system organ failure. I was deaf when I woke up. I was in the ICU for 5 days. Very nearly died. And that was August 3rd, 2004, and I've been sober since then. That resulted in an important shift in me, in that I just decided at that point, because I knew that it wasn't that I wasn't trying hard enough. I knew that I was trying as hard as I possibly could, and it wasn't that. I knew that the problem wasn't a willingness on my part. It was that whatever I was doing wasn't the right tools for what I had. And so that began a years-long process of really exploring many, many different types of therapy and different ways of trying to get healthy and heal myself. But I always did it. What was different from that moment is I didn't abandon myself. When I was prior to that moment, I had sort of, and this is to some degree what's encouraged at least in 12-step when you first get sober, I sort of turned my life and my will over to the experts, so to speak, and my sponsors and other, and I just knew I was like, I need to have a respect for what I don't know. And I need to have respect for what I
And you were in medical school, so I could say that many people in medical school and physicians, and there are plenty of physicians who have alcoholism and or drug addiction and can't face the point of being able to get help because of their status. And what messages can you give to physicians out there that they can gain some help, be able to surrender themselves and gain everything back in their life that potentially they either lost or they may lose as a result of that?
Well, what I can say is, physician or any other profession, I think the silver lining of becoming an addict is if you want to survive, you are forced to do something that every human would benefit from, which is you have to figure out how to get emotionally healthy. Because I believe, without exception, addiction is a solution that has become its own problem. And if you want to survive your addiction, you not only have to figure out how to stop using, you have to figure out how to heal the source of the pain that whatever you became addicted to was anesthetizing for you.
And you mentioned developmental trauma. How do you see that related? I mean, I'm very much a believer in developmental trauma, as we already discussed when I met with you. And how do you see that as a precursor to using drugs and alcohol?
I have a belief, a strongly held belief, that a necessary prerequisite to the development of addiction is chronic emotional pain. I don't think people that have the ability to exist in states of sort of loving self-connection, I don't think they go on to develop addictions. It doesn't mean that they don't use drugs. It doesn't mean that they may not enjoy drugs or maybe have to get to a place where they are using them too frequently and then pull back. But I really believe that every one of us that develops an addiction is because we're thing, that behavior, that substance is we're using it like a medicine to treat
Sure.
a pain waiting for us there when we stop. And I also believe that humans are not that different from one another. So we are very attuned to our differences, but in the same way that we all have two eyes, a nose, and a mouth, but we look very different. We can all tell the difference from one another. We all look different. The same goes for how we develop. The same goes for our brains and our cognitive emotional systems. And there is a way that there is a common general pathway that underlies or cause behind how you end up as an adult that feels anxiety and shame in the absence of something shaming or dangerous happening in the moment. And those are the two major sort of categories of human emotional pain is anxiety and shame. And shame is the emotion that's behind depression. Guilt is feeling like you did something bad. Shame is feeling like you are something bad. And the origin of those things is trauma, is developmental trauma. And I would go a step further and say most developmental trauma is not what I would call traumatic event trauma. I call it traumatic narrative trauma. And what I mean by that is most people who have anxiety and depression because of developmental trauma, it's not because they were attacked by a bear or because they were in a fire. Although, of course, if you are attacked by a bear or in a fire, that, of course, those can cause traumas. But the vast majority of us that have that, it's because of subtle sort of sub-threshold things that were difficult to necessarily pull out and say, oh, this was this one terrible thing that happened to me. It's more a matter of things like living in growing up in a relational dynamic with important adults around you who are either chronically invalidating or abusive or abandoning in some way. And of course, children have varying degrees of sensitivity to that as well.
Sure.
So it's something that emerges sort of as a property of the relationship that we have with our caregivers, and then to some degree as well with older siblings, with our peers.
There's so many people that end up like trying to figure out what happened to them in their life. I had a normal life. I had a perfect family. Because they were ingrained to believe that was the perfect life for them. And yet I listened to someone that she thought she had a perfect family, but when it came down to it, she didn't. Her father died of alcoholism. So it's just kind of interesting how we twist our own brain really between what is normal versus what isn't normal. And children like to do that.
Well, I would actually argue that I think that children are wired to do that.
Yeah.
There's something called neoteny, which is the retention of juvenile characteristics for long periods of time in a species, and humans are notorious within the animal kingdom for neoteny. You look at a zebra or a horse or a goat, they're born and they wobble around for a minute and then they can do essentially everything they need to do for the rest of their lives to survive. If a zebra is born or a horse is born and then a mountain lion comes by or a lion comes by, 10 minutes after their birth, the parent zebra or horse doesn't pick them up on their back.
Right.
Everybody just runs. And whereas with humans, it takes at least a decade before a human child could reasonably survive on their own. Mm-hmm. And so we are foundationally dependent upon establishing secure attachments with loving, healthy caregivers as a survival. I mean, is the primary survival drive of children. And so I believe that as part of that evolution constructed human children's brains, never to assume that ruptures in attachment were due to some flaw on the parent's part, because
they're just doing what they knew. They're just doing what they knew to do because of what they went through in their life. We don't really, unless there's an awakening around understanding that this may have affected us. And I am a product of the generation that there was no therapy or very few people.
I would say of all generations prior, I mean, it's a rare, very, very recent development that therapy has been available, and even more recent that it hasn't been severely stigmatized.
Sure. Well, this has been really, really great. I loved having you, and we got off to a rocky start trying to get this going. But Jason, Dr. Schiffman, Jason, I just really, really commend you. I want to hear more about your book. Maybe we'll come back after you've continued writing on that. How far along are you with that?
Reasonably far. So the name of the book is Epidemic of Excess. And the subtitle is the Dawn of Universal Addiction and How to Escape It. So basically, the premise of the book is that we are now all marinating in this sort of stew of hyper rewarding technologies, drugs, and food. For most of our evolutionary history, our suffering just came from deprivation and not having enough to get our needs met. And then beginning, I think, around the early 2000s, there was an inflection point, and I think actually most of, at least in the Western world, and this is not to say there isn't continued ongoing significant suffering due to poverty and deprivation, but the substantial portion of the population now is suffering because of excess. And it's the hyper activation of the reward pathway from constant exposure to hyper rewarding, again, technology, substances, and foods, that unfortunately, especially with respect to to social media and to digital technologies, are simultaneously undermining the experiences of that promote secure attachment and replacing them with experiences that promote anxiety and shame. And so the premise of the book is that this sort of inexorable process of progression that is the free market that started, way back in prehistory when somebody had more chickens than they could use and traded it for somebody with more apples than they could use. Now, it has been producing ever more potent and powerful ways of satisfying our drives, and that we are very, very close, I believe, to an era of human history where, because of the mechanisms I was just describing, almost everyone will have some form of an addictive disorder. It will become the most prevalent illness. And so, and I think there is something that we can do about it. But we have to recognize the problem.
Let's for sure. I want to have you come back and we can talk about that and what there is that we can do about it, because children are a big portion of this in our future. So thank you so much. I appreciate you, and we'll have you back.
Okay. Thanks so much, Pam.
Thank you, Jason. Thank you for joining the conversation today. If you are seeking help for yourself or a loved one, please reach out to our Feinberg Consulting team at 248-538-5425. That's 248-538-5425, and check out our website at feinbergcare.com. I'm grateful for our guests and all who have joined us today. Make sure you follow us on Apple, Spotify, or anywhere you listen to podcasts.